I'm Moses Ocan, and I will be taking a presentation of the work that I've been doing for my graduate award on antimicrobial self-medication in northern Uganda, implications on chloroquine and artemisinin genotypic resistance in the community. As way of background, antimicrobial use was projected to have increased by over 30% globally during a period of 2000-2010, with over 80% of such use occurring in the communities where self-medication, use in animal husbandry, and agriculture contributed to various extents of antimicrobial use in the communities. Self-medication in particular, which is one of the most common ways of antimicrobial use in communities. In such practice, individuals take charge of the decisions to recognize the condition which they are suffering from and choose medicines for which they need to take for those conditions, and in some cases recognize and manage adverse drug reactions that could occur from the use of such medications. This responsibility on individuals in communities is likely to increase the risk of inappropriate decisions, especially in developing country settings where there is very high levels of illiteracy. In northern Uganda, insecurity caused mass exodus of professional health caregivers, and some who remained resorted to private practice. This reinforced market-oriented focus on health care, and with the current challenge of poor maintenance of formal health care system, inadequate health services in rural areas, this is compounded by the current return to villages of former internally displaced persons, and further, the high prevalence of infectious diseases in the community. In such settings, individuals are likely to manage common illnesses by themselves, and this was the focus of this research. The patterns and practices of antimicrobial use are influenced by factors which are unique to different geographical settings globally. The use of medicines during ill health is taken as the essence of disease management in most communities. However, healthcare professionals who manage patients in hospitals rarely explore to ascertain prior antimicrobial use among patients reporting to the hospitals, and yet the extent of antimicrobial use has direct impact on microbial resistance. In post-conflict northern Uganda, the extent and nature of community antimicrobial use following resettlement of the former internally displaced persons is not known. In addition, there is uncertainty regarding the implications of such antimicrobial use on resistance development in the community. Antimicrobial self-medication is a health-seeking behavior and it's influenced by several factors, patient factors, drug industry factors, health system factors, and community factors. This as postulated in a model by Anderson, 1995. So the study was then designed into 4 sub-studies to assess the factors that could affect antimicrobial self-medication in communities, and also trace the implication of such use on resistance development. In sub-study 1, we did a systematic review of published articles on antimicrobial self-medication in low and middle-income countries, and included 34 studies with a total of 31,340 adult participants. Findings of that work is published in paper 1. The brief of review methods in this first study. The protocol was first developed following the PRISMA guidelines and registered in Prospero. We searched PubMed, Embase, and Medline databases for potential papers that could be included in this review. An example of the search string which we used in PubMed is projected above there. The papers which we selected for the review, data was abstracted from those papers using 2 independent reviewers. those papers, we also assess risk of bias using an 8-criterion tool adapted from the Strobe guideline. Data synthesis was done of the included studies using both structured narrative and quantitative methods. We also assess for heterogeneity in the included studies using I-squared test. Random effects meta-analysis was used to establish the aggregate prevalence of antimicrobial self-medication in low and middle-income countries. The summary of the flow of activities which we did in this review is projected in this PRISMA flow as established by the PRISMA guidelines. The search of the 4 databases produced 4,400 potential titles which could be included in our study. When we screened for duplicate articles, we removed 8,228 duplicate articles. That left us with 3,572 titles, potential titles of the articles that we could include in our study. We screened the titles and abstracts of the entire 3,572 articles and excluded 3,401 for various characteristics that made them not fit the eligibility criteria for our study. That left us with 171 articles. We further added 6 from the bibliography searches that gave us 1,177 articles. We screened full text articles of the entire 177 and excluded a further 143 because they were not fitting the eligibility criteria for our study. That left us with 34 articles which were eligible, and those are the articles that we assessed, and the findings of this review are based on those 34. We find from that review that antimicrobial self-medication in low and middle income countries, its aggregate prevalence we found of 38.8. This value is closely related to a value that was found on global antimicrobial self-medication in a review by Morgan in 2011. We also find that in low and middle income countries, the use of ACTs, the aggregate prevalence is 12.3. We found very high heterogeneity in the included studies with I-squared of more than 90%, with the majority of studies having potential risk of bias due to method of analysis, in which most of the studies use descriptive statistics in presenting their data. We also find that majority of the studies had potential risk of recall bias, as most reporters or researchers reported use of recall periods of over one year in data collection, and many more papers didn't report a recall period used during data collection of their published work. The determinants of antimicrobial self-medication in low and middle income countries was assessed from studies that reported to had used multivariate models in the assessment of the associated factors, and of the 15 studies included in Africa, 3 reported to have done rigorous data analysis in terms of establishing the associated factors, and they reported low level of education, non-science qualification, mild to moderate illness, age, and female gender. While in the Middle East, of the 8 studies included, 1 reported age, education, and middle income. Studies done in Asia, 8 of them, and South America, both didn't do rigorous data analysis. Inappropriate practices in non-prescription antimicrobial use from the published papers are short duration of use of the antimicrobial agents, insufficient dose of the antimicrobial agents, inaccurate indication where antibacterial agents are used in management of symptoms of viral infections, sharing of antimicrobial agents amongst the members members from which studies were conducted. These inappropriate practices in antimicrobial use are likely to increase unwanted treatment outcomes, such as treatment failures, resistance development, and or adverse reactions from medications. The reported outcomes of antimicrobial self-medication included recovery from illness, allergies, lack of cure, and or causing death. However, generally, there was low reporting of outcomes of antimicrobial use from majority of the studies from which we did our review. This perhaps is an indicator of the lack of biomedical information or knowledge amongst the study participants from where most of the studies were conducted. As conclusion of that sub-study, it is then clear from the finding that there is widespread antimicrobial use in this resource-limited setting. However, it is commonly associated with inappropriate practices. We then went and conducted community household survey in northern Uganda, where we surveyed households for their use of antimicrobial agents in management of their most recent illnesses. The findings of that survey were published in paper 2 and 3. This survey was done in the 4 districts of Noya, Gulu, Lira, and Dokola, in which adult individuals in households in the communities were recruited. This is a projection of where these districts are located in the Ugandan map. It was a cross-sectional study, and data was collected from November to December 2012. Required sample size of 884, calculated using multi-cluster sampling method for this study. Random selection of the 4 primary sampling units, which are the districts of northern Uganda. We then also randomly selected secondary sampling units, which were 4 sub-counties in each district. In each of those 4 sub-counties, we again randomly selected 3 villages, from which 20 households were selected, from where we then picked the individuals who respond to our questions. Home storage of antimicrobial agents were assessed by requesting individuals or respondents to bring out any medicines that they had in their homes for assessment. The questionnaire was first pre-tested in 20 individuals, and the information from the pre-test used to adjust the tool. Data was collected using interviewer-administered questionnaire. Data collection team was trained using the data collection tool, and the collected data edited in EpiInfo software and analyzed in Stata. We used chi-square and multivariate logistic regression in the analysis. The analysis showed that of the 892 individuals interviewed, 75.7 reported to have used antimicrobial agents in management of their most recent illness, which in most cases included fever, headache, lack of appetite, and fatigue. And also individuals reported to commonly be using Coartem or ACT, amoxicillin, metronidazole, and cotrimoxazole in management of those conditions. And these medications were mainly obtained from drug shops and or pharmacies in the communities. With the amount of medication, amount of money used in accessing these medications, ranging from 300 to 2,000 shillings. These findings are really an indicator that antimicrobial pressure from the use of antimicrobial agents are arising from mainly 3 factors. One, you have overuse, especially from the use of antimicrobial agents in minor illnesses like fatigue, for example, lack of appetite. We also find that there is misuse of these agents, probably because of inability to access appropriate health or appropriate health care in the formal healthcare system. As you see, that about 70% of the respondents use private sector. And we also see that there's risk of underuse of these antimicrobial agents, mainly because of lack of money to be able to purchase full course of the antimicrobial agents in each case where the agents are being sought to be used. We also find that about 60% of the respondents in the community reported not being aware of any regulations regarding antimicrobial use in the communities. This perhaps is an indicator of inadequate implementation of antimicrobial drug use policies in the country, where antimicrobial agents are stipulated as prescription-only medications. Yet you find that people are not aware of these regulations in the communities. The main sources of information on antimicrobial agents used included previous successful experience, past or old prescriptions, and people were getting advice from friends or relatives on what medicines to use. These are sources of information which are not in most cases accurate and could lead to inappropriate use of antimicrobial agents. The predictors of antimicrobial use from the analysis of our work showed that advice from friends and relatives, use of old or previous prescriptions, and attitudes, for example, people saying that hospital drugs don't work. In addition, members who reported to be reading drug information from sources like drug leaflets were about 37% less likely to have reported use of antimicrobial agents without medical consultation. We also found that over a third of the respondents reported to be having medicines in their homes, with most of the respondents using these medicines without any medical consultation. We further found that past successful use and regular income predicted home storage of these medicines in communities. However, female respondents were about 63% less likely to report presence of medicines in their homes. Conclusion in sub-study 2, we generally find that there is very high prevalence of antimicrobial self-medication in communities of northern Uganda. If compared with a systematic review, you find that the rate in northern Uganda is about twice that found in other low and middle income countries. We then found that Coartem and ACT was the most self-medicated antimicrobial agent in the communities. We also find that community members keep medicines in their homes and they choose to use these medicines whenever they fall ill without consulting any medical practitioner. We then went and organized study 3, in which we went to hospitals and assessed presence of recent exposure to antibacterial agents among patients who are seeking care in these hospitals to really indicate whether there has been exposure to these medications among patients coming to the hospital and what physicians do for such patients. The findings of this study were published in paper 4, and again it was a cross-sectional study in data was collected from August to September 2013 with a sample size of 410 used in this study. We used systematic random sampling in selecting the patients, and the patients were interviewed using interviewer-administered questionnaire, then requested to provide spontaneously voided urine in sterile wide-mouth urine containers, for which the urine antibiotic biopsies were performed immediately. Those who reported to have been using antibacterial agents in management of chronic conditions were excluded from this study. The urine antibiotic bioassay was performed using disc diffusion method as described by Liu and Kenavong. The standard bacterial strains of E. coli, Bacillus subtilis, Streptococcus pyogenes were used in this analysis. We also did quality control, in which we selected some samples and did reanalysis in Department of Medical Microbiology. These analyses were done in the microbiology laboratories of the outpatient departments of Lira and Gulu Regional Referral Hospitals. Diameters of zones of inhibition were entered into Excel spreadsheet,
Interview data was also managed in APM4. The two data sets were merged and analyzed in Stata. We used chi-square and multivariate logistic regression analysis. Analysis of the samples revealed that about a third of the urine samples had antibacterial activity against the test strains. This is indicative of recent exposure to antibacterial agents among patients seeking care in these health facilities. This, of course, is a challenge in patient care, especially in these communities where there is a high prevalence of infectious diseases, and yet therapeutic options for management of those conditions are limited. So the patients are more likely to be prescribed medicine that they have already exposed themselves to and fail to recover in the hospitals. Such practice may increase risk of adverse drug reactions or resistance development amongst these patients. We also found that about 62% of the patients reported using the self-report that they had exposed themselves to antimicrobial agents before coming to the hospitals. This then shows that self-report and urine antibiotic bioassays are not giving us the same findings. However, most of the patients who reported to be using antibacterial agents at home also had positive urine samples. We found that about a third of the respondents took about 5 days trying to take antibacterial agents at home before coming to the hospitals. Delay in seeking care in the hospitals is likely to lead to more severe disease development, which may make treatment more complicated amongst these patients. When we assess the predictors of antibacterial activity in the urine samples, most interestingly, we found that patients who reported to had taken more than 7 days at home since the first occurrence of the illness were about 89% more likely to have positive urine samples. In other words, patients from clerking who say that they first experienced the illness, symptoms of the illness for which they have come to the hospital 7 days ago or a week ago were more likely to have attempted to treat themselves before coming to the hospital. So this is important information for the healthcare providers as you're clerking the patients. People who report to had experienced this illness much earlier are then more likely to have used antibacterial agents before coming to the hospital. Conclusion of the study are really that we find that a third of the patients coming to the hospital have evidence of recent exposure to antibacterial agents. However, you find that healthcare professionals rarely explore to ascertain the occurrence or presence of antibacterial use amongst patients seeking care in these health facilities, which is, of course, a disadvantage for the patients. So, having done the study 2, where we found divergent use of antimicrobial agents. First, we found that SCTs, Coartem, were the most used medications of about 28 or 29%. But we also found that about 1.3% of the respondents reported continued use of chloroquine in the communities, mostly access over the counter. This is, of course, an interesting finding because chloroquine was stopped from mass treatment of malaria in Uganda 2004, and yet we still find that it is being used in the community. So we then set out to ascertain the implications of such wide or varied use of antimicrobial agents. In one case where there is too much use of Coartem, and in the other case where there is low and continued use of chloroquine. So we wanted to find the implication of such use on resistance development in the community. So in the first part of sub-study 4, we assessed the prevalence of chloroquine resistance in the community, bearing in mind the continued presence and use of this medication as found in the survey. The findings of that study were published in paper 5, Duff Press. It was a cross-sectional study done in Lira and Guru Regional Referral Hospitals. Data was collected in 2013, 2014. We selected the sample size of 430 calculated using Kish and Legere. Systematic random sampling was used in selecting the patients for recruitment into the study. Malaria diagnosis was done first by screening using rapid diagnostic tests, HRP2. Patients who had positive RDT were further screened for presence of parasites using thick blood smear. Those for which we found presence of parasites in their blood, finger prick capillary blood was collected and spotted on filter paper, left to dry in the laboratory, and stored later at 4 degrees centigrade until PCR analysis was done. A brief on current literature on chloroquine resistance coming from studies really done in various parts of Africa, Malawi, Kenya, Ethiopia, Zanzibar, Mozambique, Uganda. Most of these studies indicate presence of increased chloroquine resistance, chloroquine sensitivity, following its withdrawal from use. A mutation PFCRT76T is a key mediator of chloroquine resistance in Plasmodium falciparum parasites, and polymorphisms in PFMDR1 of Plasmodium falciparum parasites also modulate sensitivity to various medications in Plasmodium falciparum parasites. In this study, as a brief of the methods that we used, parasite DNA was extracted from the blood spots on the filter paper using Cherex resin method as described by Plow. The mutations, PFCRT76, which is a key determinant of chloroquine sensitivity in Plasmodium falciparum parasites, and a mutation in 86, in codon 86 of PFMDR was identified or assessed in this study using nested PCR followed by restriction fragment length polymorphism. Primers reported in a study by During Singh were adopted for PFMDR analysis, and then primers reported in a study by Dose 2001 were used in assessment of PFCRT76 polymorphism. For PFCRT and PFMDR, restriction enzymes, APO1, which is a wild-type enzyme, and AFL111 were used in the digestion. The products were visualized, that's the digestion products, were visualized in gel electrophoresis and classified as wild-type, mutant, or mixed genotypes following migration patterns on the gel electrophoresis. Very clear projection. However, this is an example of the migration patterns of the digestion products of AFL111, which we said is a mutant enzyme. In other words, it cuts positions in the gene that have the resistant genotype. So it cuts them into two. So you can see, like sample 4, which was a control, mutant control, FC, R3. It was cut and produced two fragments, one of about 230 base pair and the other one of about 330 base pair, giving us about 550 base pair size for the wild-type parasites having wild-type genotype. This is also an example of the migration patterns of the APO1 digestion products, which is a wild-type enzyme, meaning that it cuts the gene at position where there is no mutation into the two fragments of about 149 base pairs. So you have now the mutant genotypes having about 149 base pair length. We find, as a summary of this analysis, that PFMDR wild-type genotype is occurring after about 97% of the samples analyzed, while 1.3% had a resistant genotype, 86Y, and 1.2 had mixed genotype. This finding is generally in agreement with most studies which are reporting increase in wild-type genotype of PFMDR following the use or introduction of SCTs in malaria management. It was also further reported that SCTs are selective against the wild-type genotype for PFMDR. So the increased use of SCTs found in the communities could be favoring the selective existence of the wild-type genotype for PFMDR, as we find in our study here. For PFCRT 76 codon mutation, we find that 41.8% had wild-type or chloroquine sensitive genotype, 54.4% had resistant genotype or chloroquine resistant genotype, and 3.8% had mixed strain infections. This finding again also is generally in agreement with what other people are reporting currently on chloroquine sensitivity. That is, there is a general reoccurrence of chloroquine sensitivity in most countries in sub-Saharan Africa. However, the patterns are not the same. In some countries, resistance to chloroquine has almost disappeared. For example, in Malawi, there is 100% sensitivity currently. In other countries, the reported sensitivity is up to 60%. Kenya, Tanzania, and other countries are reporting 60%. In Uganda, we are still reporting values below 50%. A study by Mbogo in Uganda, which stressed the temporal changes in chloroquine resistance, and that analyzed from 2003 to 2012, found that in 2012, chloroquine sensitivity was up to 17% in Uganda. Our recent analysis indicate that that value has increased up to threefold to 41%, which is a generally positive trend in the reversal of chloroquine, but we still find that it is below most of the other countries. Several factors could be postulated to be causing this. The continued presence and use of chloroquine definitely in the communities are maintaining chloroquine drug pressure and thus potentially containing or sustaining the slow reversal in chloroquine resistance in the communities. But we also find that studies by Laufa in Malawi showed that the parasites which reappeared in the communities as sensitive parasites are really coming as a result of a re-expansion of those parasites that survived chloroquine drug pressure at the time when chloroquine was being used. So when the chloroquine use was stopped, the parasites which were wild type or having wild type genotypes just multiplied and then reoccurred as sensitive genotypes. That means that the starting points, the basal chloroquine sensitive parasites in the community has a bearing on how fast the chloroquine sensitive genotypes can occur. In Uganda, by the time we changed chloroquine in the treatment of malaria, resistance was being reported at 100%. While in Malawi, by the time they changed the chloroquine from the use of chloroquine in malaria treatment, the basal resistance was about 87%. So we see that these countries are starting at different levels, and that could be also responsible for the slow reemergence of chloroquine sensitivity in Uganda. Conclusion, we really find that this study shows a slow but incomplete reverse of genotypic chloroquine sensitivity in Uganda. In part 2 of this sub-study, we assessed the occurrence of artemisinin resistance in the communities, and the findings of that study are accepted in BMC infectious diseases. Again, as a brief of information on artemisinin resistance, first we find that a study by Array in Cambodia confirmed the presence of SCT resistance, being conferred to by polymorphisms in the K13 gene. These polymorphisms, these various positions, being the main predictors of delayed parasite clearance by SCTs in Cambodia. But we also find that studies recently done in Uganda and in other sub-Saharan African countries have reported occurrence of single nucleotide polymorphisms in that propeller region of the K13 gene. However, those mutations are different from the mutations obtained or detected in Cambodia and associated with delayed parasite clearance by SCTs. By methods of the analysis, the propeller domain of the K13 gene was amplified, first using the nested PCR method, and primers reported in this study by Area, which was done in Cambodia, were adopted in this analysis. The 849 base pair fragment length extending codons 445 to 726 base pair codons within the propeller domain were amplified. We did bidirectional sequencing of the nested PCR products using the Sanger sequencing. The sequence analysis were done using in 7 different steps. First, we did a visual check for good quality chromatograms. Then we did base calling to assign bases using sequence analysis software, version 5.3. Then we did sequence edit of miscalled or overlapping peaks using bioedit. Sequence similarity and identity blast search was done in PlasmoDB, which is a Plasmodium genomics resource database. We then did alignment of the sequences to the reference PF3D7, which is the wild-type Kelch protein using MEGA5. Single nucleotide polymorphism was done. Single nucleotide polymorphism analysis was done using DNSP version 5.10, where the mutations confirmed by reading both forward and reverse primers. I must say that the findings of this analysis, as reported in the discussion, were further reviewed following comments coming from the manuscript. And when we did the reanalysis, we found that there was a nucleotide shift in the site of the mutation. So the SNPs reported in the dissertation are not exactly the same as the SNPs that I'm presenting here, which came from the reanalysis following the comments of the reviewers of the manuscript, which I've just reported. So there was a shift in the nucleotide bases. So we find that it's not a very clear chromatogram, but we find that a mutation at codon 533, which is a glycine to cytosine amino acid chain, a non-synonymous mutation at codon 533 of the K13 gene, was found in one of the samples we analyzed. This polymorphism was previously reported in the Plasmodium falciparum parasites in Cambodia. However, it was not associated with delayed parasite clearance by the artemisinin agents. We also found from the reanalysis, previously this was 201, this was 508, so there was a shift. This was also 501. So there was a shift in the nucleotide base position. We found also the 2 codon mutations. This codon mutation was also reported in a recent study done in Uganda by Conrad. This 509 was recently in a paper published in February, also found in Kenya. But we really find that the mutations which are being reported in our study and in most African studies which are assessing polymorphisms, the K13 gene, are not finding the mutations which were found in Cambodia. This is a challenge now for monitoring SCT resistance in Africa, because the mutations which are being found in the studies are not similar to those which were reported in Cambodia, and yet there are reported challenges of delayed parasite clearance by SCTs in Africa, although a recent study by COPA in Uganda failed to demonstrate delayed parasite clearance by SCT in Uganda. There have been general reports of delayed parasite clearance by SCTs in Africa and in other sub-Saharan African countries. So the dilemma facing malaria or SCT monitoring currently is that the mutations, the K13 gene, are not the same as those which are being found in Cambodia. And this is the general challenge. All the other areas where these studies are being done are not finding those mutations. So in conclusion, we find that this study shows presence of K13 propeller gene polymorphisms among Plasmodium and falciparum parasites in northern Uganda, which might be an indicator of the occurrence or presence of artemisinin resistance among the Plasmodium and falciparum parasites. General study limitations, we could not confirm using chromatographic methods the reported presence of antimicrobial self-medication in communities. We also could not detect specific antibacterial agents that patients reported to be using as they report to the hospitals. In sub-study, that was sub-study 3. General conclusions. The prevalence of antimicrobial self-medication in northern Uganda, as found from the survey, is about twice the value that is found in other low and middle-income countries. We also found that a third of the patients reporting to the hospitals have evidence of recent exposure to antibacterial agents. In sub-study 4, we found that there is a slow resurgence in the prevalence of chloroquine-susceptible Plasmodium and falciparum parasites in northern Uganda. The other part of the sub-study also found presence of parasites carrying K13 propeller gene polymorphisms in northern Uganda. Recommendations. Enforcement of existing regulations involving over-the-counter access and use of antimicrobial agents need to be considered. We need to improve community awareness of appropriate antimicrobial use, most especially using educational programs. We need to develop programs to help track and reduce overuse of antimicrobial agents in communities. We also need to do regular surveillance of the K13 molecular marker of artemisinin resistance to aid monitor artemisinin resistance in the communities. So the implications of those recommendations are that currently we have community health volunteers. We also have village health teams in the communities. These persons could be trained to help teach or share or inform communities on antimicrobial or appropriate antimicrobial use practices in the communities. However, strategies to improve antimicrobial use must involve or consider both private sector, community members, and healthcare professionals. Future studies arising from this research, first, of course, is to validate the K13 propeller gene polymorphisms reported in this study and in other African studies. This would help aid monitoring of SCT resistance in Africa. We also need to evaluate to find out treatment outcomes for patients who are prescribed antibacterial agents, which they have used prior to coming to the hospital. So what happens to them when they are treated, yet they had used these medications before coming to the hospital? We have also said that there are limited therapeutic options in treatment of infectious diseases in communities. So it's more likely that the healthcare professional will prescribe the same antibacterial agent that the person has tried to use and failed to improve. No one knows what happens to these people when they are treated. So there is need to evaluate and find out the outcomes of managing such patients in the communities. We also need to find out really if inappropriate antimicrobial practices in the communities of northern Uganda are more common when people use medicines without consulting medical professionals. This slide is a summary of my thought process as an experience I shared or I got from this study. I find that reading this book on tragedy of the commons, the author states that people's pursuit of their own interest can lead to destruction of their common good. In our setting or in our study, antimicrobial use, when people decide to use antimicrobial use, the advantages to the individual, that is the patient, or the prescriber, or the pharmacy technician, or the pharmacist who is dispensing this medicine, the individual advantages they get from the use of these antimicrobial agents has a big public health problem. In other words, it has a problem in the public domain of health. So when you use medicines by your own decision, you have an impact where that use can have on a public domain of healthcare. Really, individuals decide to use antimicrobial agents by their own decisions. Once they do that, they ignore societal perspective. They ignore the implications of such use on the health service system. When you decide to use the agents, you forget that when you use the medicine the way you use it, it has a larger impact to the society and to the healthcare system. This challenge, which we studied as antimicrobial self-medication, if we prescribe technical solutions like the one I postulate here, such solutions need to take into consideration the human values or the ideas of morality. People have to change their morality. People have to change their values to know that the way they use medicines have implications to other people who may need those medicines in the future. So when we ensure that people change their values and morality, perhaps the challenge of antimicrobial use, together with the technical solutions we suggest, like improving awareness, access to appropriate treatment, will help in reducing or alleviating the challenge of antimicrobial self-medication. I would like to sincerely thank my sponsors for the study, MESAO MEPI Consortium, MESAO mentors, Professor Nelson Sewankambu, I don't see him around, Dr. Yukari Manabe, this lady, really without her much of this work would not be in the form we present today. I thank her for the work she did. Dr. Leah Okello, I think I see her in the audience. She and the other mentors did a lot in the MESAO team. And Professor Emilio Vuga for their efforts to help shape this work. I want to thank in the same vein, most sincerely, my supervisors, Professor Obua Celestino, Professor Jasper Ogwaro-Keng, and Dr. Freddy Bwanga, who are all in attendance. The doctoral committees of Professor Paul Wako, Dr. Dunstan Bagenda, who unfortunately relocated to US, I think 2 years after the study started, but we kept communicating online. I want also to thank my MESAO PhD fellows, some of whom are in this attendance. I want to thank the study participants and the data collection team. Thank you so much.